Thank you and welcome everyone to this special edition of ISTH SSC on the Case. Our Pediatric Thrombosis and Hemostasis Virtual Case Conference Series features today a memorial webinar honoring the lives and legacies of Drs. Maureen Andrew and Patti Massicotte. Our first esteemed speaker today is Dr. Paul Monagle. Dr. Monagle is a professor and past chair of the Department of Pediatrics at University of Melbourne in Australia, former acting head of the Cancer Center at Royal Children's Hospital in Melbourne, and the long-standing group leader for hematology research at Massacott Children's Research Institute in Melbourne. He also serves as a clinical hematologist at Sydney Children's Hospital. Dr. Monagle is known and loved by many in the field. I will endeavor to give a very brief description on him. He is internationally recognized for leadership expertise and published research in the field of pediatric thrombosis and hemostasis and coagulation science. He is a past chair of the Pediatric and Neonatal Subcommittee of the ISTH SSC, leader of the Pediatric chapter of multiple successive ACCP Antithrombotic guidelines and the recent ASH Pediatric Thrombosis guidelines, and a member of the NIH Working Party into thrombotic disorders in pediatric cardiology patients, among many other committee and leadership roles. He is a statesman in the field with a vast portfolio of work spanning from the bench to clinical trials, and has over 300 publications with over 10,000 citations. Dr. Monagle is also an avid and respected teacher of a broad array of students ranging from undergraduate to PhD. Our second esteemed speaker is Dr. Gabrielle deVeber. Like Dr. Monagle, Dr. deVeber's reputation precedes her. Many in the field know and love her, and I will only very briefly give you a synopsis of some highlights of her long and storied career. She is Professor Emeritus of Pediatrics at the University of Toronto, pediatric neurologist and founder of the Children's Stroke Program at the Hospital for Sick Children, and Senior Scientist Emeritus at the Hospital for Sick Children's Research Institute in Toronto, Canada. She is chair of the research committee of the Child Neurology Society, and her vast and unique early career training path included fellowships in both neurology and thrombosis and a master's in research methodology. Dr. deVeber continues to enjoy a prolific career in research, publication, guidelines, leadership roles, and mentorship. And among these many groundbreaking accomplishments that many of us take for granted as a fundamental building block for continued advances in the field of pediatric stroke, she is the founder and past long-standing director of the Canadian Pediatric Ischemic Stroke Registry and the International Pediatric Stroke Study, which have enrolled more than 6,000 infants and children to date and have established a great part of our current knowledge base of epidemiology, etiology, and risk factors, diagnosis, management, outcomes, and prognostic factors in the field of pediatric stroke. She has won too many awards to list in this forum, has over 300 publications, and is a cherished mentor and teacher. And I want to thank very sincerely Drs. Monagle and deVeber for speaking today. Dr. Monagle.
Good morning. It's actually Dr. deVeber. I think both of us are equally prepared to go first, but since I'm starting with a tribute to Maureen, we decided that I'll go first if that's okay. So I did want to thank the organizers for this very special event. It's been 20 years, almost to the week, that Maureen passed, and as you all have heard, Patti passed recently as well, so it's very appropriate that we honor them in this way. My job is to share a few brief comments on Maureen, and I'm realizing that for many of you who have joined today, you would not have worked with Maureen, and that's a new thought for me because usually my colleagues have worked with her and know her. But for those of you that don't know her, Maureen really was the champion who built this field of pediatric thrombosis and literally laid the map out and the roadmap for what we have continued to do. She was a devoted, pioneering clinical scientist in the truest sense, and devoted her career to thromboembolic disorders in infants and children. She was a gifted clinician scientist who really showed the marrying of clinical care of children with studying their conditions, either in the basic lab where she first laid out the developmental profile of clotting in infants and children and the age-appropriate findings that built developmental hemostasis, and then animal studies that established the pathophysiology of pediatric thrombosis in rabbit models. In parallel, she built the human pediatric thrombosis studies, including the Canadian registry that built into more population-based studies, and then developed the first randomized controlled trials. All of this with the mentorship and help of those of us who were privileged to be trained by her. All of her research was inspired and informed by her clinical care of children and infants with clots, and she did this through her own clinics at McMaster and Sick Kids, and then through institutional programs elsewhere via the 1-800-NO-CLOTS line, which ran as a voluntary 24 hours a day, 7-day a week physician advice line. And during that, she really helped care for thousands of children, mainly in the United States. And then finally, her vision was that the 1-800 would no longer be required because we would build protocols. And that happened. So Maureen's gift was really her ability to inspire collaboration across specialists, across geographic boundaries, including initially the National 16 Centers Registry in Canada, and also to establish consensus in a field where there wasn't a great amount of evidence in the beginning. She mentored hundreds of students, including all of us who are presenting to you today, and was a passionate mentor, and really made our lives and our careers into any successes that we've had, I believe. She was also a wonderful human being outside of her career. She was a champion Scottish dancer. She was a very gifted pianist. She was kind and funny. She cared deeply about others, especially children. Maureen loved deeply and was deeply loved as a doctor, a mother, a teacher, and a friend. It's been 20 years since we lost her, but her legacy lives on in this next generation of caregivers who work in this field of pediatric thrombosis together. And these are just some brief pictures of her caring for children, writing at Paul Monagle's home where they wrote the book. And these are our protocol books that she helped champion that have been built over the years. And this is Maureen as a woman and a mother. So I'll turn now to my presentation on stroke. This presentation is titled Pediatric Arterial Ischemic Stroke, Management Beyond Antithrombotic Therapy. I have no financial disclosures other than my NINDS grant, as well as expert witness consultation. So in the talk I'm going to give, I hope that we can help you understand target mechanisms and underlying conditions for stroke, where the clot is different in some ways, although basically it's fibrin, red blood cells, platelets, and the fibrinolytic system. But the target organ is the brain instead of the kidney or other organs. So we think about in building treatment plans for these children, we think about the mechanisms that underlie the clots as well as the mechanisms that underlie the brain injury. And we look at the clinical outcomes to target which are the highest yield outcomes. And then we look at mechanism-based treatment options. So this is a panel of MRI scans on children, newborn, 2-year-old and 75-year-old, all of whom have had an arterial ischemic stroke. You can see that the lesion looks very similar in the brain. And that is indeed the case. However, underlying this macroscopic view of this white infarct in the territory of the middle cerebral artery, many differences exist in the pathophysiology, some of which were championed by Maureen, but also in the outcomes, in the ability of the brain to rewire and recover. And these need to be kept in mind when we're looking to treat. So causes and outcomes are different. The common pathophysiology underlying adult, childhood, and newborn stroke is thrombosis, either in situ or from a cardiac source, occlusion of a brain artery, and then focal ischemic brain injury. but it all starts with thrombosis, fibrin clot, platelet clot, and the balance between those two, depending on the physiologic conditions of blood flow speed and whether it's arterial or venous, and leads to the damage that results in these outcomes, which are basically three exclusive outcomes. Children have complete recovery, they can die from their stroke, or they can have incomplete recovery. And we're all targeting these final two outcomes. So here's the slide that reminds us that children have a very different capacity to recover. Death and neurologic deficits still occur, and we still need to focus our attention on improving those, but you can see complete recovery in the newborn, the child, or the adult is quite different. We have about a 6-fold better complete recovery in children compared to adults. Death is rare but important, and incomplete recovery results in about 1/3 of children having a clinically significant deficit compared to 80% of adults. So again, the outcome is different. So looking at death, death is caused by recurrent infarction, hemorrhage into the stroke bed, which is a rare cause, and something called malignant MCA syndrome. And what this is the reaction of the infarcted brain to massive swelling, resulting in herniation of the brain out of this rigid skull downward, and death from brainstem injury. This is the commonest cause of acute death, and usually occurs within the first 4 to 5 days. The treatments that we can offer are neuroprotective care to help prevent full damage in the infarct. At the edges of the infarct, there are areas that are partially perfused by the remaining healthy arteries, for example, the anterior or posterior cerebral artery in an MCA stroke. And these are areas that can convert, depending on the neuronal activity and the tissue state, they can convert to death and become part of the infarct, a growing infarct, or they can be protected by what we do at the bedside. I'll talk mostly about recanalization therapy because that's a very hot topic. All of this audience knows about the importance of prevention of recurrent stroke. And then finally, rehabilitation therapy, which is the mainstay of treatment for that 33% with incomplete recovery. So here's a case. This is a 10-year-old that we followed at Sick Kids. She arrived with a ongoing focal seizures for 3 hours in a previously healthy girl and a right hemiparesis. You can see on this initial CT done at 5 hours, there's a low density area here. This is the right middle cerebral artery territory. You can also see a dot here, which is the dense clot filling the branches of the MCA. Her seizures were really intractable and ongoing, and that played, I think, an important role because she went on within hours to show the beginnings of shift. So now the right hemisphere is starting to swell with the stroke, and it's starting to push things over to the left. And here we can see on the right panel that at 40 hours, she has a very established infarct and very significant midline shift. And at this point, her pupil dilates because of the mass effect, and she goes on to a hemicraniectomy, but unfortunately dies. 12 out of our 66 children with MCA infarcts had malignant MCA, although many were saved by hemicraniectomy done early. And we found that prolonged seizures conferred a 25-fold increased risk of going on to malignant MCA syndrome. So this is the one we want to avoid, and that's why they need ICU care. In the ICU or at the bedside, our goals of neuroprotective care are to optimize energy supply and demand, and we can do that by increasing or optimizing energy supply, meaning good oxygen, good blood flow with good blood pressure, adequate glucose, which the brain requires, and we can decrease the energy demand, very importantly in children, by treating fever, which rapidly increases the metabolic rate of those dying neurons, and also by preventing seizures, which are very common. 30% of children present with seizures. Recanalization therapy is very new, very controversial, and very exciting. And this is really targeting the arterial occlusion, where we're hoping to reopen and reperfuse the brain on time so that most of the brain doesn't die. But if we do this after the brain has established its ischemic infarct, we're not really protecting anything. We're just producing reperfusion of dead tissue. So the timing is crucial, and that's been the problem. So the benefits of recanalization in children have to be balanced with the risks. And we know that as time proceeds on the x-axis, the brain becomes more and more resistant to any kind of recanalization. And excuse me, the other risks of putting a catheter up inside an arterial, a small artery in the brain become higher. Arterial wall injury with rethrombosis, new infarction, reperfusion of dead brain resulting in more injury and in hemorrhage, and also the radiation dose and contrast diaload of angiography. Despite all of these, we're trying very hard to get children in on time so that we can confer some of the same benefits that adults get from this. So recanalization therapy includes intravenous TPA and endovascular approaches, which are intra-arterial TPA, and then mechanical thrombectomy, which has really hit the stage in terms of adult thrombosis, and which is being used more and more for children. So I'll take you through a few studies. The first is one from last year showing from Kate LaFond and her tipsters group, Thrombolysis and Pediatric Stroke, that thrombolysis, intravenous TPA, appears to be very safe in children. If treated within 4.5 hours, IV TPA was associated in 26 children with no symptomatic hemorrhage or parenchymal hematoma. This produces a power estimate of about 98% likely that if there is a risk, and if you treated more than 26 children, the risk would be less than 15%, and there's a 93% likelihood that it's less than 10%. So this is the first study. Mechanical thrombectomy is usually done with a stent retriever that is pushed up through the arteries, collapses the clot against the wall and captures the clot, and then is withdrawn to remove the clot and theoretically reperfuse. This is the result we all hope for before thrombectomy. The red arrow shows the blockage in the middle cerebral artery, and after thrombectomy on the right, you can see recanalization. And this is the focus of a lot of us in treating this, but the neurologists among us are more concerned with, well, what is the effect on the brain? So we have to be careful we're not just looking at the plumbing and the appearance of good arteries that have reperfused, but what does it mean for the brain? Does it mean recovery of the brain, or does it mean further infarction and hemorrhage and death? Another study done in 2019 was published, and this is really a pooled case study of all the literature. And this showed among 110 cases that were published, usually as individual cases or as small clusters of cases, a very high angiographic success as well as a good clinical outcome in 90%. Death in 2 patients and symptomatic intracranial hemorrhage in 1. So this looks very optimistic, but the conclusions were patient selection and publication bias was likely. This is by the authors of the pooled review. Mechanical thrombectomy can be considered for children, and a prospective multinational registry is needed. The next study was one out of Europe in collaboration with a handful of American cases. And this was a retrospective analysis of 73 children that were treated over a 2-decade interval at 27 centers, mainly in Germany and Austria. And when collected, these children appeared to have a benefit from the thrombectomy, with the median stroke severity scale, where high is bad, improving from 14 at the time of mechanical thrombectomy to 4 by day 4. This is a significant recovery, and we do see significant recovery in children who are admitted with stroke. So we've always wondered, well, what's the natural history comparison? And we don't have that from this study, but nevertheless, this is a very informative study. Complications were seen in 7%, including arterial spasm, symptomatic intracranial hemorrhage, and malignant edema, as I showed you in the earlier case who died. Younger patients had worse outcomes, less than 6 years. So the conclusions were thrombectomy appears to be safe and favorable in most. Age 6 may be the cutoff, where below that it's probably futile more often than not. This study may support clinicians' practice of off-label thrombectomy in childhood stroke in the absence of high-level evidence. The next study, and the final one I'll talk about, was done to really counteract the results of the Save Childs while supporting the need for that kind of a study. And here what was done was a prospective enrollment of 42 cases across the US and Australia. And these 42 cases were built on the back of a NINDS trial for TPA that had discontinued years earlier, but the Tipster trial continued enrolling without funding support from the NINDS. They then compared what we called in the trenches TPA and thrombectomy to the 133 pooled literature cases. That included 19 of the Save Child's cases that had been published outside of that 73 case series in clusters or small single case reports. In the trenches, what they found was that the results after thrombectomy showed a 3-point improvement in NIH score compared to a literature case improvement of 8 points in the NIH score, with an odds ratio of 6-fold for better outcomes in the literature cases, concluding, as most of us already worry about, that literature reports appear biased to good outcomes. Rigorous data collection is needed before treatment guidelines can be developed. So that's the controversy that's raging right now in pediatric stroke. And stay tuned. I'm sure Save Childs and the Peter Sporns and others are going to help us elucidate, working together with our International Pediatric Stroke Organization. So we've joined forces and hopefully we'll shed some light on this. The AHA, the American Heart Association statement in 2019 was very cautious to limit consideration to children with persistent disabling neurologic deficits. These are very much the adult early cutoff criteria. So a pediatric NIH stroke scale score greater than 6, older children with larger arteries, treatment decisions made with neurologists expert in pediatric stroke, and intervention by endovascular surgeons experienced. So in the final section, we'll talk about recurrent stroke. Neonates with regular stroke do not have recurrence, but those with cardiac conditions, congenital heart disease, do have a 9% recurrence risk. That's important because you'll read neonates don't need anticoagulation. But this subgroup, which is about 25% of neonates, do have the same recurrence risk as children with stroke. Children do have a recurrence risk, 7% by 1 month, 12% by 1 year, and it varies by cause. So arteriopathy is a higher likelihood of recurrence. These are the antithrombotic treatment trends over the past 25 years. And you can see that the use of no treatment from 1992 in the blue bars has decreased to the adjacent red bar in the late 90s to currently less than about 30% who get no treatment. And some of those have contraindications. Antiplatelet treatment has stayed fairly constant between 20 to 40% over those epochs. And anticoagulant therapy has made up the difference. So increasingly, children with acute arterial ischemic stroke are getting low molecular weight heparin. This is the International Pediatric Stroke Study map showing in this one publication. There are now 35 publications from our group. This one was led by Neil Goldenberg, our host, and you can see the range of anticoagulant as first treatment in red in the pie charts ranges widely, and the US being the lowest rate of anticoagulants. So meanwhile, we do have published pediatric stroke guidelines, the AHA, the Australian Pediatric Stroke Guidelines. In my opinion, these are the strongest guidelines, the best. We have some from the UK, the Royal College of Physicians, and the American College of Chest Physicians stopped in 2012. We also have the Canadian Stroke Best Practice Guidelines. So the stroke neurologists and the thrombosis hematologists have combined to do these guidelines together, and they are interim and low evidence because we don't have randomized controlled trials for most of our treatments. We do have clinical trials in development. One's called PASTA and FOCUS for inflammatory arterial disorder in childhood, focal cerebral arteriopathy. And for newborn stroke, we have exciting neuroprotective trials with erythropoietin and stem cells intranasally. And these are enrolling but not yet published. So stay tuned for those. And we also have a number of rehabilitation trials in neonates and children that are very successful. So here's the IPSS. If you're not joined and you're interested in pediatric stroke, I encourage you to join. With the advent of this multi-center approach, we've had a dramatic increase in the number of publications in pediatric stroke. And this is going to only continue with the evolution of the International Pediatric Stroke Organization, which is partnering with the IPSO and which will be meeting in Vienna next May. So conclusions. Stroke outcomes and mechanisms drive treatment approaches. Our current treatment decisions are challenging due to a lack of clinical trials, but consensus-based guidelines are available and are continuing to build based on current evidence, and the evidence is growing. Expertise and pathways, as well as research in pediatric stroke, are rapidly expanding, and these are really the wave of the future. So thank you for your attention and the honor of being able to present on behalf of Maureen and of Patti, my close friend and dear colleague. Thank you.
Thank you, Dr. deVeber. And we're opening it up to some questions, and we'll start off with Dr. Monagle has a question for you. Paul, would you like to pose that?
Sure. Thanks, Gabrielle. Thank you. Wonderful talk and a wonderful tribute to Maureen. I was interested in your thoughts about the role of the experience of the operator in making a choice between mechanical thrombectomy over thrombolysis, and how important you think that is, and then also how young you think you can currently go with the technology, and do you think that's going to improve over the coming years?
Okay. The operator dependence is huge, as you may know. It's the technique that's used, as well as the stent retrievers, and more in pediatric stroke, the use of ultrasound and targeted clot lysis using ultrasound are more likely to be beneficial than the stent retrievers that are present in adults mainly. If you don't have expertise in small arteries, you probably shouldn't be doing pediatric thrombectomies below 5, and that's pretty standard. I think arteries below age 5 are smaller. We know that. Above age 5, they're similar age. But the most important part for the operator experience is that they have very good experience with adults, but also with pediatric other conditions like vein of Galen malformations, which are very commonly treated with endovascular approaches. I think the team approach here is crucial. At Sick Kids, the team includes the hematologist, the ICU, the neurologist, and the interventionalist. And I think an interventionalist functioning alone, especially an adult interventionalist, is probably not safe. So that's my opinion on that.
Thank you, Dr. deVeber. I will ask a question as well. It was a great presentation. You pointed out very nicely that there are ongoing trials in neonates on neuroprotection in older children. The question and controversy around hyperacute therapies to restore blood flow, improve outcomes. But you also pointed out really nicely a pretty high rate of recurrent AIS in subgroups of children. And you pointed out trials of glucocorticoids in childhood AIS with arteriopathies. Can you comment on what you think the future is in terms of trying to chip away at the recurrence risk in childhood AIS and cardioembolic neonatal AIS?
Sure. I mean, I think I don't have to emphasize to this audience, but I usually do emphasize that one of the strongest predictors of recurrence in all of the studies that we've looked at where it's been tested is thrombophilia. So there's been a tendency to kind of sideline thrombophilia and not pay attention to it outside of your field and maybe in your field. But in fact, thrombophilia, I think, does help us select levels of likelihood of recurrence. We know that from some of our studies, for example, in the cardiac population. So I think the wave of the future is, number one, multi-center studies. Number two, easily administered and easily monitored treatments. And we'll hear more about that in the rest of this session. Number three, I think targeting those with the highest risk and defining who those are is going to be the way forward. And I think by doing that, we're going to have higher rates of recurrence and therefore lower sample sizes required. And as these multi-center networks of investigators are built, we're going to be able to achieve randomized controlled trials. So we already have had the beginnings of that with our childhood stroke treatments. So hopefully that answers your question.
Very well. Thank you, Dr. deVeber. And I think we have time for one more question. It looks like Dr. Chan has posed. Anthony, do you want to ask your question?
Great, Gabrielle. Is there any difference between the neonatal brain and the older children in terms of tolerance of ischemia?
Wow, that's an amazingly good question. And I think we don't really know that. I think what we know is, number one, the cell suicide that accompanies ischemia, the cascade of cell death from either excitotoxic injury or inflammatory injury after an acute stroke, the time course for that is much longer in newborns than it is in children, much longer, like at least 7 days. So the idea that you should give up on neuroprotection if it isn't given in the first 24 hours does not apply really to newborns. And we don't know yet about children, but it's probably somewhere in the middle. Tolerance for ischemic infarction in the newborn brain is confounded by the fact that acute stroke in newborns has about a 90% rate of seizures. Probably because that's how we diagnose them. Otherwise, they don't show signs of stroke. They don't have hemiparesis. So we see them usually a day or days after the stroke has occurred, after multiple seizures. And finally, they get neuroimaging and we see this big stroke. Therefore, we don't know how long the penumbra lasts, the area around the core of the infarct that's being partially perfused by the healthy arteries. We don't know whether it's obliterated in hours or whether it's still salvageable days later. So I think the question is an excellent one, and one that I think the reality is newborns, because of their longer window of neuronal salvageability, are going to be amenable to some of these neuroprotective therapies that will be too late for children once they come to diagnosis. So hopefully that answers.
Thank you so much, Dr. deVeber. And I'm hearing some pounding in my ears, which I know is not my carotids from auscultating them. That is the virtual applause that we're all hearing right now for your wonderful talk, your wonderful Q&A. And we're going to turn it over now to Dr. Monagle.
Thanks very much, Neil, for the introduction, and it's a pleasure to be back speaking again with Gabrielle and Anthony, and along with Patti, we were Maureen's fellows together through the late 1990s, and we have continued to keep in touch and work together, and I think that's a testament to the way that Maureen taught us to work as a team and to work together. I'm going to talk to you today about developmental hemostasis and the pathophysiology of thrombosis in children, and I don't have any financial disclosures to declare. So in thinking about developmental hemostasis, that was the field that really was kicked off by Maureen. And I could speak for the whole 20 minutes about the virtues of Maureen, but I think the two things that I will say is, as Gabrielle said, incredibly kind, but an extremely rigorous scientist who demanded absolute rigor in everything we did and was not interested in publishing anything in which you could not explain how it was going to improve the lives of children. And that was a really strong flavour that she instilled in all of us. So when I was a young haematology trainee, these publications came out, and Maureen happened to come to Australia to give a talk. And I said to my boss, that's who I want to go and work for. Can you arrange for me to meet her, please? And so he invited Maureen to the Royal Children's to give a talk, and I met her over lunch. And then the following day, I went and met her at her hotel and went home that night and said to my wife, we're heading to Canada to work. And that was the start of a great partnership from my perspective. Of course, since Maureen started that field in developmental hemostasis, there are many others who have continued the work. Our group has done some work in it. Ulrike and the German group, the French, the Dutch, and the American groups have all understood the importance of knowing what developmental hemostasis looks like and what it looks like in your particular population and on the analyzers that you're using. And that's led the ISTH to recognise the importance of it, both for diagnostic laboratories in the reporting of paediatric samples and, of course, in the way that we monitor anticoagulation in children. But it wasn't until some later publications, and this is one by Chantal Attard in 2013, that we started to address some broader questions around developmental hemostasis. Up until then, most of the studies had been the functional assays that we use in the day-to-day clinic. But in this study, Chantal looked at the antigenic levels of the proteins, and those quantitative differences didn't always correlate with the functional differences. And I thought that this paper was particularly interesting as we move into the era of the direct target drugs that specifically target individual proteins, so that the changing levels of those proteins across the different age groups, and here I've highlighted factor 2 and factor 10, may be really significant in the way some of those drugs actually work. And so that's important for us to understand. Of course, developmental hemostasis doesn't just involve the quantity of proteins. There are also changes in the structural differences of proteins, and we've looked at a little bit at fibrinogen and at antithrombin. But I think it would be fair to say that the structural differences that occur with age in many of the proteins remain unknown and, in fact, are poorly characterised. And, in fact, almost all of the ELISAs that we use have been developed in adult plasmas, and so whether or not they actually accurately capture the protein amounts that we see in children remains an unknown question in many circumstances. And how those differences impact on specific target therapies also remains unknown. Of course, it's not just the plasma proteins. This is some work from Christina Yip, who was one of our PhD students, and we worked with Matt Linden, our platelet guru, who of course trained with Alan Michelson in Massachusetts. And this was looking at monocyte platelet aggregates in children versus adults and the mechanism of their binding. And if I take you to this next slide, what I can show you is that in the top panel of the adults, here are the monocytes, here are the platelets bound to the monocytes, and you can see here that the P-selectin is now being co-expressed on the surface of the platelet and is contributing to the binding. So it's a P-selectin mediated mechanism, and we know that in adults about 5% of platelets are bound through this mechanism to monocytes, and that goes up with increasing risk of cardiovascular disease. In this, the lower panel, panel B, when we're looking at the infants, what we actually see is that what we found was about 30% of the platelets were bound to monocytes. But when we look at this one, here's the P-selectin still safely tucked inside the granules, inside the platelet. and as yet we don't fully understand what the mechanism of that binding is. So the cellular interactions are different with age, and in the platelets as well. And then, of course, the third component of the coagulation system, the vascular endothelium. We did some work, or Evan Neesham did some work with Maureen back in the late 90s, showing in animal models that the glycosaminoglycan content was different and changed with age in animal studies. And other people have looked at things like the intimal medial thickness and shown that that's different in adolescents compared to young adults. And when we get to the final product of all of those changes of plasma proteins, of platelets, and we get to what the actual clot looks like, we find that the ultrastructure of the clot is different in children versus adults. And again, this is work led by Vera, who has co-headed my lab group now for over 20 years. And when you look at the clots, as you can see, they're different in terms of the fibrin strand thickness and the pore size, which will then impact on the tensile strength of those clots. And that may well be why we see differences in their response to anticoagulation and to fibrinolysis. So what do we know so far about developmental hemostasis? We know that there are differences in concentration, function, and structure of the hemostatic proteins. We know that there are differences in the response to many anticoagulants, that there are differences in the response to antiplatelet agents. We know that there are differences in the platelet phenotype, the response to agonists and their cellular interactions. We know the mechanisms of thrombin generation and inhibition are different. And as I've just shown you, the final blood clot structure and the response to fibrinolysis is different. Of course, it's not just the coagulation proteins are different. It's many of the parameters that we measure on a day-to-day basis in our clinical patients that change with age. And of course, one of the most groundbreaking studies that has led this work has been the Canadian Caliper paper led by Khosrow Adeli out of Sick Kids that have collected samples on over 12,000 healthy children and looked at over 185 lab biomarkers and made a significant contribution of our understanding to how those change with age and how we should be thinking about reporting pathology tests in children. There are other groups, the KIGS group or the German group have been a big group, but many other groups around the world have worked on this area. Over the last 6 years, we've been running the Happy Kids study, which has collected over almost 6,000 samples, and a couple of the main differences that we have between our study and the Caliper studies have been twofold. One, the inclusion of neonates in almost all of the studies. Two, that rather than actually do the major study on one analyzer and then use transference to compare to others, we have aliquoted the samples that we collected off every individual. And so for here in this slide, I'm showing you the creatinine, and we've aliquoted the samples into 6 different aliquots and then used the 6 different platforms that are available on the world to do a direct head-to-head comparison of those results. And the last major difference is that we have favoured reporting pediatric pathology results as continuous with age as a continuous variable to get away from this age partitioned problem that you see, where these boxes here are the standard age partitions that are used in many publications. And of course, you can see that if your child is here, they'll have a result that is marked as abnormal. And then the next day they'll have a birthday and suddenly they become normal again. And that's, we've all had that experience of having children referred to us for abnormal pathology, and you just wait until they flick into the next partition and now they become normal again. And I think that if we can now, with electronic medical records, there's no reason why we can't move to these continuous age ways of presenting the data. And not only do I think that gets rid of those problems and spurious results being reported, but it also enables you to much better follow a changing trend over time in a patient that you're following. So just like a growth chart, you can start to see whether or not your patient is crossing centiles, and that may give you an early indicator of disease, even if the patient is not yet outside of what is termed the reference interval. And so out of Happy Kids, we've had significant publications that are continuing on with that work. Of course, it's not just the parameters that we measure for our routine pathology. The whole plasma environment has changes. And again, this is more work that has been done by Vera Ignatovic. Vera didn't get to know Maureen overly well, but I think they would have got on very well because Vera is also incredibly kind, but one of the hardest scientists I know, and certainly has no problems in telling me when I'm wrong, which is a wonderful thing to have in a partner. So this is our work where we look at the plasma in neonates versus adults, and you don't need to be a proteomic specialist to see that there are many proteins that are present in one and absent in the other. And in fact, there are over 100 proteins that are either absent or present in the neonates, but not there in the adults or other way around. And that's without even getting into the fold differences of protein. And that will play out in the way that we then utilize drugs that are plasma bound. And on the right-hand side of the slide, I'm just showing you the differences in the just number of proteins that bind heparin in the plasma of children of different ages. So it's an important concept for us to understand. Of course, one of the interesting things is what drives these changes. And of course, the coagulation proteins are not just involved in coagulation, they're involved in inflammation, immune responses, and angiogenesis. And whether or not the changes in concentration and structure that we see are related to actually the coagulation role, or whether or not that is just compensation for changes that are in other physiological pathways, as yet we don't know. And that would be the same around platelets. And of course, many of these changes are involved in the pathogenesis of adult diseases. And so whilst, of course, it's important that we understand the physiology of neonates and children, it may well be that by better understanding the developmental changes, we can start to look about how we can actually start to alter the disease burden within the adult population, or at least develop better biomarkers for identifying that early disease. And so it may well be that the path to saving the adult population is indeed through our children. The second part of the talk I'm going to talk to you about is thrombosis and the epidemiology of thrombosis in tertiary pediatrics. And again, this was an area that was pioneered by Maureen. And we know that the thrombosis rates are very different in children to adults, and that this is actually a disease of sick children. And in fact, now hospital-acquired VTE is said to be the second largest cause of preventable harm in paediatric hospitals, second only to CLABSI. And as we know, the rates of VTE in community-based children is very small, but in hospitalised children is 100 to 1,000-fold. A high percentage of children have additional risk factors, with central venous access being an important part of that. But it would be fair to say that the natural history of VTE in children remains unknown in many circumstances. This is the data from Leslie Ruffini's excellent paper in 2009, which showed the increase over the previous decade of the rate of clots in children. And I think we all feel that to be true. But one of the key things that we have to think about when we're looking at that literature is the difference between symptomatic and asymptomatic thrombosis. This was a really important paper that was related to Sophie Jones, PhD, one of our anticoagulant nurses, during which she looked at children who were in the intensive care unit who had a central line put in place, and took about 200 consecutive children, ultrasounded them within the first 3 days of the line going in, and we kept the results blinded to the treating team, and then followed the children for 2 years outcome. And what we found was that there was no difference in rates between the children who had thrombosis in that first 3 days in terms of what their long-term outcomes were and the rates of post-thrombotic syndrome compared to the children who did not have clot with the central line. So I think it's fair to say at the minute we don't know the natural history of asymptomatic thrombosis in children, and there's a lot more work to be done in that area. Of course, there are specific populations that we continue to be troubled by. The first grant I ever wrote with Maureen was the grant for a randomised trial of aspirin versus warfarin in Fontan patients, and we eventually got around to publishing that data in 2011, 2013. It was mostly due to the generous help of Jack Hirsch and Mike Gent, who supported me in continuing that trial after Maureen's death. And that question of how we can best manage the Fontan patients has been an ongoing challenge. And I think the most recent excellent work done by Chantal Attard in her PhD with long-term follow-up of patients through the Australian and New Zealand Fontan registry would actually seem to answer the question that for many patients, aspirin is certainly adequate therapy and not requiring warfarin, which is great. And of course, over time, the complexity of the patients that we are asked to get involved in to manage their thrombosis has increased. And all of us now will be very used to spending a lot of time looking at children who are on ECMO, which is one of the most expensive therapies offered in paediatric hospitals, and bleeding and thrombosis and stroke remain major complications of that therapy. And of course, that is closely related to the VADs, and this was where Patti really came to the fore, and her leadership in developing the Edmonton protocol and teaching people around how to anticoagulate VADs was something that she was exceptionally well known for, although I think her greater contribution was actually her development of home warfarin management strategies, along with Mary Bauman, and the Empowerment Project and work, I think, was some of the most groundbreaking work that we saw. This was the last time I saw Patti alive at my house in 2019, along with Anthony, although I continued to speak to her right up to her death, and we miss her greatly as well. So I can't finish a talk on age developmental hemostasis without just talking about how is it relevant to the current pandemic. And one of the things that struck us when COVID first came along was the bizarre epidemiology for what is essentially a respiratory virus, where children seem to be affected far less than adults. And given that the pathophysiology of severe disease really relates to the formation of microvascular thrombi within the pulmonary vasculature and a specific and different coagulopathy, we wondered whether, in fact, that developmental hemostasis might be playing a role. So we decided to look at that in vitro, and so we set up experiments on HUVEC cells with a media above, and then we either left the cells uninfected, infected them with COVID-19, or used influenza as a control, and then we bathed the cells in plasma that either came from healthy children, healthy adults, or vasculopathic adults, and the plasma was all collected pre-pandemic, and so we knew that the plasma was all in fact COVID negative, and then we looked at the clotting outcome that we saw after that. We did not activate the plasma, so the driver to forming thrombosis, we just neutralized the citrate. So the driver for forming thrombosis was what was going on in the cell surface. And here the scanning electron microscopes, and again, if you look at the healthy child up here and you look at the vascular path exposed to SARS-CoV down here, you can see significant differences. And when you then look at the fibrin clot characteristics, and in particular the fibrin thickness, which, as I said before, we know relates to the tensile strength of the clot, we can see that the clot in children was thicker than the adults, and the thinnest clot, which therefore means the hardest clot to break down and the hardest clot to lyse, was seen in the vasculopathic adults. And so it may well be that developmental hemostasis has got a contribution to the differing pathophysiologies that we currently see with COVID. In those same experiments, we then went on to look at what happens if you add drugs to the system, and it was interesting that the direct thrombin inhibition by bilirudin made no difference to the clot, nor did defibrotide, but the heparinoids were actually very effective at stopping the clot from forming. And although I haven't shown it here, you could actually take the concentration of heparin down exceptionally low, and unfractionated heparin was by far the best at preventing the clot from actually forming. And that, I think, has played out with what we've now seen in the clinical scenario of what is the most effective thromboprophylaxis and treatment for patients who have clots in the setting of COVID. Of course, heparin may well have some other interesting roles in COVID. We know that the mechanism of infection, when the SARS-CoV virus and the spike protein comes in contact with the nasal epithelium, that the first step is it binds to heparan sulfate on the nasal epithelial surface, that then co-locates it to the ACE2 receptor, and it's via that it gains entry into the cell and then is able to replicate. And that, therefore, if you actually put heparin into solution, that you can bind up the spike protein and prevent that interaction, and that heparin binds the spike protein exceptionally widely, and so is going to be agnostic to any variant that actually happens. What we don't know yet is whether there are differences in heparan sulfate distribution on nasal epithelial surface in children compared to adults, and that is the subject of a study that we are currently doing right now. But what we do know is that if in cell culture, in either vero cells or kidney cells, in human bronchoepithelial cells, that if you actually put a heparinase or unfractionated heparin on those cell surfaces, that you actually bring the infection rates from the SARS-CoV virus down to almost the same as the uninfected experimental arms. And we've confirmed that with experiments in Melbourne, that with bathing the cell surfaces with heparin, you can lead to an 18 to 60-fold reduction in viral titer within the cells, which makes an interesting proposition that maybe intranasal heparin may be a very effective pre or post-exposure prophylaxis therapy for the SARS-CoV-2 virus, and we're working towards a clinical trial of that right now. So I'll stop there, and I just want to thank my whole team who have done most of the work that I've shown you and who always work incredibly hard, and I hope that if I asked them, they would say that I've tried to instill in them the same values that Maureen instilled in us. Thank you very much.
Thank you very much, Dr. Monagle. And we have a question for you from Dr. Manwani regarding your early slides on P-selectin-mediated platelet monocyte aggregation. And the question is, at what age does this occur? And would you predict at younger ages prior to this phenomenon being demonstrated or being important that inhibitors of P-selectin like crizolizumab would be less effective in sickle cell disease?
Good question, and I think the answer is that we don't know the answer to that yet. I think what we can say is that there may well still be in disease P-selectin-mediated binding of platelets in children, but that there is an awful lot of platelet binding to other cells, both monocytes, neutrophils, and lymphocytes, through non-P-selectin-mediated mechanisms in children that are not seen in adults. What the physiological relevance of those are and what the pathophysiology importance of those are, I think remains unknown, and there's a lot more work to be done.
I'll pose a second question for you, Paul, and it was really a phenomenal talk that took us across such a broad spectrum of science and clinical knowledge. And your most recent work in COVID-19 models. Can you give us a sense with your expertise on the challenges of endothelial cell models, and specifically, have you or others looked at pulmonary endothelial rather than HUVEC cells, and do you see kind of the same phenomenon with regard to the fibrin clot structure and the anticoagulant inhibition thereof?
So at the minute, that model that we developed, was a novel model. No one had ever looked at how we could actually look at the way the cell surface was interacting with clot formation. Of course, we were really limited in the mechanisms by which we could measure the clotting outcome, because it all had to be done inside a PC3 laboratory. So we had to be able to kill everything before we could actually bring it out of the lab. And that's why SEM was probably the best mechanism for looking at it. We did, in the initial instance, try and look at some other cell types, using some stem cells to grow some different cell types, but none of them liked the SARS-CoV-2 infection, and all of the cells died. So the HUVEX was one of the strong cell lines that would tolerate the infection and let us look at it. Again, I think there's a lot more work to be done in that, and we just need someone to generate the funding to enable that to happen, I think.
Well, it's some really exciting work that you and your colleagues did, and I believe Dr. deVeber has a question for you as well.
Thanks. Brilliant talk, Paul, as always. My question is, do you know yet what the net difference in fibrinolysis is clinically for newborns versus children? There's opposing information, as you may know, with differences in the levels of Pi1 and TPA and some of the other fibrinolytic elements. But I think you made the observation, if I'm not misremembering, a long time ago that despite that, the newborn seems to be able to melt clots quite quickly. So any further information on that?
Yeah, I think it's really interesting, and you know, the fibrinolytic system is a tricky one to examine, and we've been trying to work on that for a while. I know Neil's actually looked at that as well, and it's not that easy to get a really good handle on it. So that's something that we're still working on. But you know, clinically, our feeling is we all see children who look like they've got a pretty good clot, and you give them a bit of anticoagulation, and the clot dissipates really quickly. Even just with anticoagulation, not with fibrinolysis. So presumably, once you actually shut down the thrombin generation, the fibrinolytic system of the child is pretty effective, or the original tensile strength of the clot is actually not anywhere near the same as what it is in adults to begin with, which I think would be supported by some of the work that we've actually done. I think one of the problems that we have whenever we look at those systems is that we tend to look at them all in isolation, and then trying to actually figure out what the total net physiological effect of all of those things is actually really challenging. And I think that's still an ongoing discussion that Vera and I often have as to how can we put all of that together and think about the total net effect of the way things are looking.
Well, that is a great way to conclude the Q&A with a very global picture, global hemostasis, and global picture of the field. So thank you very much to Paul Monagle, to Gabrielle deVeber, and to the other discussants. I'm going to now hand it over to co-moderator Dr. Christoph Mahle for the rest of the program.
Thank you, Neil. And I'd just like to say that I'm very glad to take part in this webinar today, because I was privileged to work with both Maureen and Patti, as well as most of today's speakers, when I was a fellow with that group in the late 90s. And the work of Maureen and her dedication and enthusiasm led the foundation to the many advances in the field in pediatric thrombosis hemostasis that Maureen's team members, particularly Patti, Gabrielle and Anthony, and many former fellows and associates that have further pursued over the last 20 years. And this is the basis for what we are discussing today. I would like to go on to introduce Anthony Chen to speak about antithrombotics in children. Just would like to say that, as Anthony is well known probably to almost all of you, he's professor of pediatrics at McMaster University. He's chair of the Pediatric Thrombosis Hemostasis program there, has been associated chair of research as well as head of division of hematology and oncology at McMaster, and he's also clinical scientist with the Thrombosis Atherosclerosis Research Institute at McMaster. Anthony, among many other functions, has been also chair of the Pediatric and Neonatal Thrombosis and Hemostasis Subcommittee of the International Society of Thrombosis and Hemostasis. His research, his laboratory research, is also focused on developmental hemostasis and its interaction with pediatric diseases and therapeutics. But he has also been designing and conducting clinical studies in pediatric thrombosis and pediatric stroke and hemophilia over more than 25 years. Last but not least, Anthony has been continuously serving the around-the-clock telephone consultations service of 1-800-NO-CLOTS that was originally created by Maureen Andrew. And finally, Anthony was awarded the Order of Ontario for his work in advancing the care of children with thrombosis and stroke. So Anthony, please, the floor is yours.
Good morning. This young child, name is Jonathan, and he so happened to be my son. And he actually gave me another view of Maureen and Patti, because at the time before he had his open heart surgery, Maureen will call me every single day just to ask me to update her about Jonathan's status. And before he went into surgery, he also made sure the family is well fed, because she knew that we were going to be so worried we wouldn't even go for our meal. And then around the same time, when we were at the hospital sick children's, Patti would come and visit us every day. And if my memory served me, Mary Bauman would come as well to bring us lunch. And in some way give me a perspective of, other than the science that they are really great in advancing, is how we care for each other, and then at times translate to how we care for our children. Now let's get a little bit philosophical before we get into the antithrombotics, because I think science, philosophy actually gets a lot into the science, and then in some way that's how I actually view the research as well. So hopefully, when we actually think about antithrombotics, we will actually be able to get every view and perspective so that we can weigh the risk and benefit and apply into each therapeutic decisions so that we can actually get the best outcome for the patients. Unfortunately, at times, when we actually create these puzzle pieces, like making a story so we can have a pictures, some of these, when we have all the puzzle pieces, it's easy. So we can see the picture very easily. Just like if you like to go to the house through the road, if all the pieces are there, we can travel down that road and we'll get to a good decisions. There are times when the puzzle pieces are not complete, the picture is not as beautiful, but we may still be able to actually get to the house. However, there are times when the puzzle pieces that is right on the road, we really don't know how to get there, and that's the time we actually have to go and generate the evidence. And then philosophically, I think that's what we actually have been doing for our children's in future that actually got thrombotic disease. I'm just going to read through this because it's a way to think about how we have been progressing in the last 20 years for me after Maureen died. It's really through thoughtful, iterative trial and error is often required to obtain a diagnosis that in turn predict prognosis and guides optimal treatment. Whether we realize this or not, this is the same process. We update our opinions, and each imperfect piece of clinical information becomes available. And so Maureen actually go through this iterative process as well as with Patti, and then hopefully we are going to actually go through that iterative process. About antithrombotics, amongst many guidelines as alluded to by Gabrielle, I think these two guidelines, although this one is published in 2012, there will be no new versions of a similar sort of format, but it's worthwhile for us to actually go back because there is still a lot of good information there. And you can also appreciate the progress that has been made. And the more recent one is in Blood in 2018, 3 years ago already. Now, when I actually get to antithrombotics, I first ask about what is the goal of the antithrombotic. As you see in the pictures earlier, my son, he so happened to a catheter-related thrombosis in the subclavian vein. So I actually have to ask myself, what are we trying to achieve to treat that blood clot? So preventing the clot being bigger, and so as it get bigger, it may actually break loose, and we like to prevent these pulmonary embolism if it is traveled to the lung or if it is in the brain to have a stroke. reduce the chances of recurrent VTE, just like we like to reduce the chances of having a stroke for a child with a stroke, or reduce organ dysfunction caused by thrombosis. So then we actually have to kind of look at what is the information that is available to us to guide us to this goal, and then whether the risk and benefit is clear in each of those situations. Some background information, although we already kind of can glimpse on, this is published 20 years ago in the year when Maureen died. It was a prospective study doing ultrasound on umbilical venous catheters and then looking at portal vein thrombosis. In fact, when we do the screening, in some way, these are asymptomatic clot. More than 40% has silent portal vein thrombosis, but even without any therapy, that may actually address the question by Dr. deVeber. 50% of these clot that is identified by this imaging modality resolved without anticoagulation therapy. However, 10% of them will progress. How do we actually know which one is going to progress and which one is going to resolve on its own, that is without anticoagulation therapy? There are also other data published now, this is 2016, comparing the lowest curve actually gives rise, which is a non-line related clot for PTS-free survival, comparing to those that is line related clot. So depending on the etiology, the outcome will also be different, which suggests to us maybe the antithrombotic therapy, we have to adjust it according to the etiology as well. And furthermore, even the neonate with the line-related clot, and then comparing to the non-neonates, that is a line-related clot, the neonate again has a better outcome in terms of PTS-free survival. So that gives us a sense of we have to think about the age group as well as the etiology, and that may actually make a difference in terms of the intensity and the duration of anticoagulation therapy for children. Now, I'd like to bring you back. This is back in 1992, because it's an important piece of information, although this randomized controlled trial is done in adults. It's really comparing aceclumurol, you can say warfarin, plus heparin, compared to just using warfarin alone as a treatment of DVT in adults. Okay, it's a randomized controlled trial, and this trial is actually stopped early because there's a significant number of events in the group that only receive warfarin. So that actually why you are seeing some of the trials coming out using the new oral anticoagulants is with a preface of heparin or heparinoid therapy before you use the DOACs. Okay. And there's a lot of data being generated by the international community, especially with Maureen and Patti, in terms of use of unfractionated heparin, the low molecular heparin. And the largest cohort that is reported in use of vitamin K antagonist is also by the group lead at that time by Werner Streif from Austria. Okay, and I'm not going to repeat those data there. I think by now most of us are very familiar with it. And that actually contrasts, they are, for the unfractionated heparin, there may actually be new use of it, as alluded by Paul, how it may actually binds to COVID, and then if it's anti-inflammatory. And also, the use of this anticoagulant is probably not going to go away anytime soon, and I alluded to it later on. And the use of low molecular heparin, with a lot of years of experience, we know how to use it, we can measure it, but with its limitations as well. Now, I'll get to the two antithrombotics that has been recently approved in various jurisdictions to be used in VTE treatment in children, okay? And these two, I would say, are the only two anticoagulants that has been approved for use. The first one is the Bicatran. The objective of this study is to study a dosing algorithm, as well as the safety and efficacy of the Bicatran in children with VTE. The lead author, Jackie Halton, so happened to be a colleague of Maureen back in the late 80s and early 90s at McMaster. This is a randomized non-inferiority trial. Again, there's an initial phase from 5 to 21 days with parental anticoagulation therapy, which is heparin and fractionated heparin or VanderPluym, requiring anticoagulation therapy for these patients for at least 3 months with the different age categories. Okay. The endpoint that they use, you have to recognize, is a primary composite efficacy endpoint with an intention to treat analysis that include complete thrombus resolutions, which we know is not going to be 100%, freedom from recurrent VTE and a VTE-related death. And the margins of difference is 20% for this inferiority trial. In this slide, it demonstrates to you the statistical analysis, so there's no difference between the standard of care and the Becker trend in terms of the non-inferiority of the primary efficacy outcome. No difference at all in terms of the bleeding episodes, although there's one death on the standard of care arm that's deemed not to be related to the therapy. And so the conclusion of this study is age-adjusted and weight-adjusted dabigatran dosing algorithm was appropriate in children from the birth to less than 18 years of age and is non-inferiority to the standard of care. However, I would like you to make aware of the limitations that is cited in the article. First, 10% of the patients was discontinued for the dabigatran with one dose adjustment, and which means in the trial, there's dose adjustment, which is unlikely to be used in real life, okay? So there's a potential you will not get into the range that we would think that we are going to get into when we use this drug. And second, they actually cited that because of the exclusion criteria that limit the external validity, and further data in the real world is actually required. And there are some patient population that would not be appropriate, as cited in the monograph as well. Say, for example, pediatric VTE in active cancer patients, antiphospholipid antibodies, absorption problem because there's oral medication with small bowel disease. They come in different formulations, capsules, orals, pellets, and solutions. And they cannot really be exchanged because the way of absorption is actually different. Okay, so you have to pay close attention to the dosing. I highly suggest you work with the pharmacist because it actually tends up to be fairly complex. And then with the creatinine clearance is less than 50 mL per minute, and there's no data available, and it should be avoided for this use. And the next few slides just show you the complexity because you have to go by the weight as well as the age. And I will not go into the details. So if it is approved in your regions, I think in Europe, in European unions as well as US, you would actually have to start looking into the availability of these formulations as well as work out a good strategy before you decide to use them. The next drug that is approved for children in VTE, the deVeber. The lead author is our co-chair, Christoph. And it's a multi-center randomized controlled trial. However, the outcome that they use is actually symptomatic recurrent VTE. Okay. Suffice to say, the symptomatic recurrent VTE is 1% for the patients receiving viroxaban and 3%, and there would be no difference according to the hazard ratio. If we actually use at the clot burden at the end of this study, it seems that there is significant reductions of clot burden in the viroxaban comparing to standard anticoagulation therapy. Major bleeding is fairly similar, 3% in the children with viroxaban. They are all non-major, 2% in children. Apparently, there will be no difference. So the conclusions for this study also lead to the approval of the drugs in children, is that using rivaroxaban, there's a slow rate of recurrence, very similar to the adult trials. But I have to remind you one thing is how the patients get in the trial. Are those trials represented in the real world data? This is a retrospective study looking for children that is less than 2 years of age and to see how they would actually be excluded and eventually how many of these children potentially can get needs anticoagulation therapy would actually fits into the trial. Okay. From the top of the curve here, it's about 101 patients that will actually require anticoagulation therapy. By going down through each exclusion criteria, you come down to somewhere around 12 children. That is less than 2 years of age that would be actually eligible for the trials. So when we are going to use the anticoagulants for these young children, I think at the present time, the best way to do it is really going according to the inclusion-exclusion criteria in the clinical trials, because the data is not going to be representative in the larger patient populations. Now, this is a graph that shows how dosing are being used in adult indications. That in itself is actually, there's a variety of ways of using that drugs. And then comparing to, this is in pediatrics. They come in oral suspensions or tablet size, and it goes up to 3 times a week. The younger the patients, the more frequent you have to give it, to twice a week, to once a day, when they actually get to the adolescent age group. So which means we also have to work with the pharmacists just to familiarize with ourselves the dosing regimens that can be used in these patients. And then I would like to bring your attention to the fact that there are some data published in terms of the use of rivaroxaban in the CSVT. Again, the recommendation is you really have to actually balance the risk and benefit. There's not enough data, even when it's published, to be able to make a strong recommendations to use it in this particular populations. And then for the younger ones, as I said earlier, for 6 months of age who at birth less than 37 weeks, have a body weight less than 2.6 kilogram, has been feeding less than 10 days, those babies probably should not use the rivaroxaban dosing as actually being approved and published at the present time. So there is a good article that is actually compare of these two anticoagulants. I'd like to use it to highlight a few things. One, the bioavailability of the Bicatrend is only about 6%, okay? And then the Bicatrend is dialysable, but the rivaroxaban is not. The protein binding is significant in the rivaroxaban. So in patients, say for example, with hypoalbuminemia, alluded by Paul earlier, there is patients with comorbidity like nephrotic syndromes. So that may actually not be appropriate because it changed the protein bindings to medications. And then also the drug interactions that you have to be aware of when you choose to use this drug. I'm going to go through this, the next few slides rather quickly. The QR code allows you to get onto those website, and then you would be able to review those informations. This one is about the coagulation testing. Although routine testing for this drug is not recommended or not needed, however, at the initial phase, you may still like to know about what drug is available in your lab in case you want to know about what the level is going to be, although there is no correlations exactly with the drug level to efficacy. Mind you, the Bicatrend is an antithrombin agent, and the Pixaban, edoxaban, or rivaroxaban are anti-10A agents. So just knowing the mechanism of how it works, you figure, say for example, thrombin time or APTT is going to be sensitive to the Bicatrend, and then you can use this test as a way to guide you whether there is the Bicatrend in the system, but you may not be able to tell you how much the Bicatrend in the system unless you have specific tests for it. And so these QR code will get you to the Bicatrend published by the Thrombosis Canada in terms of the monitoring. Key fact is actually, I pointed out earlier, there's variability in terms of the different tests to the Bicatrend. You can use it as a negative information in the sense if the thrombin clotting time or a sensitive PTT is normal, suggests to you there is no Bicatrend in the patients. But you do have specific tests. You can test for the level, but you have to verify with the lab that you actually have it in your own lab. With rivaroxaban, and then I just want to highlight, apply same for the big trend and with rivaroxaban is no routine coagulation laboratory monitoring is required, although this is written for adult patient populations. However, because there's no monitoring, it would actually be good to review with the patients periodically for clinical assessments to ensure adherence, because no matter how good the drug is, if they don't take them, you will not get the therapeutic effect. And that's what I would do myself is, I'm actually, when I put the patient on this, on rivaroxaban, because the big trend is not available in Canada or not approved in Canada for children. So I'm going to focus on rivaroxaban, is I would randomly actually check the sample to see whether it fits in the model that is actually done in the phase 1 trial, so that I know that the real world data kind of fits into, at least from the level perspective. And so as a way for me to learn about how to use this drug in the real life. And you probably can do the same for the big trend as well. Now, in terms of the reversal, of course, there is no data in terms of reversal using these antidote. Either rusumab is the first agent licensed specifically for the big trend, okay? But there's no data in pediatrics. And similarly, the guidance for the Adaxanan alpha, and then again, there's no data in pediatrics, but so you're actually aware of it. And you probably can use it by the time the patient gets to 16, 17 years of age, but they would probably work more like an adult. Now, there is one caveat that you have to be mindful of is there's data to suggest these oral anticoagulants do get rise to heavy menstrual bleeding in patients comparing to warfarin. So in here, we say using warfarin as a reference, these are the relative risk of increased menstrual bleeding for across the different oral anticoagulants. It seems that the big trend have a relatively lower risk. However, for this particular study, the baseline risk of warfarin and association with the heavy menstrual bleeding seems to be higher comparing to the other study. So we still have to actually find out how the big trend will behave in this particular issues. Now, when in a teenager, when the menstrual period only started, it's not really kind of get into a stable routine. Whether you would like to use the oral anticoagulants is actually up to you to assess the risk and the benefit. Now, there is a IPTN network, and there's a DOX registry, so that we'll collect real life experience in terms of how DOX behave and being used in children's. And then in Canada, through the Canadian Pediatric Thrombosis Hemostasis Network, we are producing guidance documents in terms of how people would like to start using this anticoagulant in a cautious way. Having said that, this is the only anticoagulants literally approved to be used in children's. There are many issues remains and require resolutions. Say, for example, use and monitoring unfractionated heparin in bypass or ECMO, formulation of warfarin because it's still required for artificial heart valves, and antithrombotic in specific patient populations. And then I'll highlight a couple of these randomized control trial. I think some of these results is going to be available soon, like the KidStart program led by our chair, Neil, and then a fixed study looking at a way adjusted fixed dose. So in some way, no need of monitoring, but easy administrations of long-molecular heparins in neonate. And I come to the conclusions. The bigger trend with rivaroxaban are approved for use in children in some part of the world. But I think it should be used according to the regimens in the clinical trial and the study formulations. And I encourage the audience to participate in the post-marketing surveillance program in other DOX trial for different indications that would actually accelerate our knowledge as well as the safety and efficacy in the use of these newly developed drugs. And there are many studies that are still required to optimize the antithrombotic therapy in children. And in here, I'd like to thank my mentor, Dr. Andrew. I call her my contemporary Dr. Massacott. That we started this journey together, and hopefully we will continue. And the ISTH to organize this webinar with 2 co-chairs and the international colleagues that participate here, as well as in many other trials that actually make our success in improving the life of children. Thank you.
Thank you very much, Anthony, for this very clear overview, particularly for your thoughtful and philosophical comments initially, and for wrapping up with some of this open issues still. I feel we are quite progressed in time, so I would ask the audience to send in any questions that you have by chat, and Anthony can answer them either now or we can later answer them by email.
Dr. Chan, can you speak to some of what you think are the key unanswered questions around the novel anticoagulants and potentially future ways of anticoagulants for pediatric thrombosis management or prevention?
Right. So, safe example, I think I listed in one of the slides, it alluded to earlier, safe example in some of the cardiac patients, and that's their ongoing study. We use anticoagulants for the Kawasaki patients with giant aneurysms or specifically infantines. As I alluded to earlier, I think as the pathophysiology of these clots could be different, and so we may not be able to directly translate what is in the trials. And also within the trials, if you actually look at the groupings, although you can say they're all clot, but a clot is not just another clot, as we can see maybe in the neonatal period, or I refer to Lyme-related clot. And the intensity or the way we have to tackle those clot may actually be different. And I refer back to even in the adult study using with rivaroxaban for arterial thrombosis. At times, it may actually need to be a combination of those antiplatelet or antithrombotics to make it optimal. So there are still plenty of questions needs to be asked. Cardiac in one questions, and say, for example, patient with short gut syndromes, although they are rare patients, but they are Lyme-related clot, but absorptions will be actually unknown. And other large group of patients, as we IBD patients, they're having GI bleeding, absorption issues. How do we actually anticoagulate them to be able to optimize them and also to ensure safety? And so there are plenty of those that are actually being required. And also, mind you, there are effects that may benefited in the treatment of a clot that without knowing when you use the heparinoids. It's the anti-inflammatory effect, but that may actually be limited to the initial phase of the anticoagulation therapy, but we will still have to explore how this is actually going to impact on the long-term outcome of the patient as well.
Thank you. We have some more questions incoming via the chat, so maybe we have time for a few more. But Anthony, can I ask you to give short responses? So we have Dr. Davila is asking, can you identify any potential contraindications or concerns regarding the use of DOACs in children with sickle cell disease?
I would think the key question will go down to is especially when they have strokes, whether that would actually increase the risk of bleeding or recurrent bleeding in stroke. And then other than that, I would think the hematocrit of the patients actually change. The dosing informations, I would think that may actually be skewed. And I would think in those particular situations, at least knowing the level and understanding, at least we are achieving a similar sort of drug level that can give rise to anticoagulation effect would actually be useful. I'm not sure there's a contraindications, but I think in the sickle cell patients, sometimes the thrombin generations in vitro in vivo is actually different. So the drug actually requirements and how we dose them may also be different.
Thank you very much. I'd like to introduce Mary Elizabeth Bauman. She's a adjunct professor at the Faculty of Medicine and Dentistry at the University of Alberta. She works as a nurse practitioner in the pediatric VAT and kid clot thrombosis program. And she has been working with Patti Massicotte for decades, actually, but also worked at the Hospital for Sick Children already together with Maureen Andrew and some of the fellows of that group. I remember that time as well. As was already mentioned, Patti Massicotte and Mary did a lot of work in coagulation for ventricular assisted devices and ECMO, as well as the self-control of anticoagulation, particularly in adolescents and children. Mary is very well suited to speak about Patti Massicotte, and I'd like to ask you to give a tribute to Patti.
Good morning. It's my privilege to make this tribute for Dr. Mary Patricia Massacott, known by all as simply Patti and fondly memorialized as the Queen of Thrombosis, who passed away in September of 2020. Patti completed her undergraduate degrees in biology at the University of Waterloo, medical doctor at McMaster University in Hamilton, Ontario in 1986, and then went on to complete an 8-year medical fellowship with Doctors Jack Hirsch, Jeff Whites, and Maureen Andrew in the departments of internal medicine and pediatrics at McMaster. She then went on to complete her master's in science in health research methodology in 2001. Patti started her academic career along with Dr. Paul Monagle and Anthony Chan at the Hospital for Sick Children and University of Toronto in 1996, and moved from associate to assistant professor in 2000. At Sick Kids, she was sub-investigator on 2 renowned multi-center and multinational randomized clinical trials in children, investigating the safety and efficacy of low molecular weight heparin in children, Revive and Protect. In 2003, Patti and her entire clinical and research team were recruited to Stollery Children's Hospital and the University of Alberta. There she was appointed professor of pediatrics, receiving the Pedia Ollie Endowed Chair, which was established for pediatric thrombosis. At Stollery, she established the internationally recognized Kid Clot program, participating in multiple clinical trials over the years, including most recently Einstein Jr. and Kids Clot. Patti co-authored hundreds of manuscripts. Those she was most proud of included the American Heart Association Evidence-Based Guidelines for Management of Thrombosis and Thrombophilia in Children with Congenital and Acquired Heart Disease, which was published in Circulation in 2013, as well as the CHEST supplements she co-authored with colleagues Dr. Chan and Monagle in 2004 and 2008, which remains still the cornerstone for management of anticoagulation and thrombosis in infants and children. Patti demonstrated great leadership in the area of pediatric thrombosis. She was the chair of the perinatal subcommittee of ISTH from 2002 to 2005, in addition to countless other chair and co-chair positions, too many to mention. She was co-investigator with numerous other major pediatric centers, research and clinical, in the submission of the NIH grants, organizer of the Gordon Conference for Medically Assisted Children in 2019. As her career matured, her passion in research and clinical interests focused on thromboprophylaxis of congenital heart disease and extracorporeal membranous oxygenation, or ECLS. She was sub-investigator and co-author of the Antithrombotic Therapy Guidelines for the North American Berlin Heart IDE study and presented to the FDA device panel as part of the expert team. Additionally, she was member of the Protocol Development Committee for the NIH NHLBI Pumpkin Study, as well as the chair of the Developmental Antithrombotic Guidelines. She was consulted and an invited member of the NIH NHLBI funded working groups, including thrombosis in pediatric cardiology and congenital heart disease, rethinking new technologies to facilitate pediatric and neonatal clinical trials in hemostasis and transfusion medicine, and finally the perinatal stroke workshop. Patti has been a guest lecturer on over 70 occasions internationally, including Harvard and Oxford. She has over 160 peer-reviewed publications, numerous editorials, and invited manuscripts, as well as 14 book chapters in pediatric thrombosis. Patti, the person, was deeply human. I remembered last night as I was having my leftover turkey sandwich from Thanksgiving dinner, how much Patti would love to share turkey sammies at lunchtime when we worked together. Patti was enthusiastic, fun-loving, generous, inclusive, yet ever focused on her goals, that of improving the lives of children. She stayed connected to the front lines of patient care, taught and mentored countless trainees, and empowered those around her to be the very best that they could be. She was a devoted mother, raising 4 beautiful children. Patti experienced multiple health challenges, and throughout all, her determination and optimism was matchless. She loved those who were close to her, and for those people, the world is a little dimmer without her. For all of us, Patti was a remarkable role model for health providers, scientists, and women internationally, demonstrating astounding passion for her field and the children she cared for. Thank you.
Thank you very much, Mary, for this very beautiful tribute to Patti that doesn't leave any questions for the time being. Thank you very much. And we will just move on now to our last speaker. I'd like to introduce Dr. Christina VanderPluym. She's a pediatric cardiologist at Boston Children's Hospital at Harvard School of Medicine, where she's also assistant professor. She actually had the privilege to train under Patti Massicotte at Edmonton, and she's now the director of the Ventricular Assist Device Program and director of Cardiac Antithrombosis Management Program, as well as co-director of Stroke and Cerebrovascular Center at Boston Children's. She has been involved in the creation and establishment of ACTION, the Advanced Cardiac Therapy Improving Outcomes Network, and her interest and research is focused on stroke reduction in complex congenital heart disease and mechanical circulatory support. Dr. VanderPluym, please, the floor is yours.
Thank you very much, and it's a privilege really to be here today speaking to with this esteemed group about people who have absolutely shaped my career. I have no relevant financial disclosures, but my disclosure is that I'm not a hematologist, but I've had the privilege to train, work, learn, and laugh with Dr. Patti Massicotte. And just quickly before I jump into my presentation, I wanted to just express that because of Patti, I've learned so much, and she's ultimately shaped who I am as a doctor, as a mother, and as a person. And when I think of Patti, the first word that would come to mind was generosity, because she had a generosity of her time, of her passion, of her enthusiasm. Her kindness and humor was infectious. She could walk into a room and you knew immediately when Patti arrived based on her smile that lit up the room and that laughter. That would be absolutely infectious, because the second she started laughing, even if it wasn't funny, somehow you still laughed along with her. She demonstrated to us a timeless style and flair for life. And as part of the Action Network, we commemorated her by putting her into a lot of our information and educational content for families and patients alike. And when the videographers came back to us with the first graphic of Patti, there was something wrong with it immediately. We knew it didn't totally embody who Patti kind of represented to most of us. And it's because it lacked the heels and her classic black suit and all of the other very stylish clothes that she inspired me to kind of look for at every conference, always going on a shopping adventure. And even as an amazing person, she had this relentless desire for innovating and going forward with academic achievement. And through all of this, she did it seamlessly as a mother and a mentor. And while she was a mother to 4 amazing children, she was also a mother to countless patients and their families and trainees who she's raised along the way. And for that, I thank her because she's fundamentally become the fabric of the modern history of VADS in children. And so I'd like to just briefly talk about the fact that VADS in kids is still a very infantile field, really beginning just back in 1991 with the development of the Berlin Heart X score in Germany. And following by that in 1996, it gained CE mark approval in Europe. And the first child in North America was just implanted back in 2000. And by 2004, the New York Times had picked up a story about a 5-month-old that was implanted at Stanford. And it was really the buzz created by this story, followed by parental push and interest that really put pressure upon the FDA to request an IDE trial from Berlin Heart. And Berlin Heart fundamentally created a group of experts in the field, of which Patti was that expert in creating not only kind of the protocol for the study, but primarily focused on the antithrombotic regime, which was one of the major adverse events or effects associated with mechanical circulatory support at that time. The IDE trial began in 2007. And by 2011, FDA had granted approval of the Berlin Heart X score. And interestingly, it was around that same time that kind of off-label use of the HVAD, or these are intracorporeal devices where the pump is internal to the body, began, and application of its use in children also began in an off-label fashion. And by 2012, use of intracorporeal devices had now began to kind of supersede that of paracorporeal devices like the Berlin Heart, and we were now discharging patients on VADs, and HVAD as well as the HeartMate 2 at that time began to become more mainstream. And so by 2017, VADs were now an accepted form of treatment for end-stage heart failure. Discharge was common, and there was also an increased trend of use of direct thrombin inhibitors, which I'll talk about in just a moment. And now, in 2021, DTIs are the primary anticoagulant for paracorporeal devices, such as the Berlin Heart, in 90% of centers. And I'm going to discuss a little bit about how this evolution in antithrombosis management occurred. And I think it's important to appreciate where we've come in terms of improving outcomes, primarily hemocompatibility-related outcomes as it pertains to VAD. And when people think about VAD and mechanical circulatory support, one of the most dire complications or consequences of long-term support has been stroke. And between 2005 to even 2015, over that decade, there was a multitude of single-center studies, as well as the North American IDE trial, that demonstrated a pretty stable or consistent number of cerebral vascular events, around 29%. So we would quote patients that a third of patients would likely have a significant cerebral vascular event, of which the vast majority of these were ischemic strokes. And interestingly, the timing of these events were generally within the first 2 weeks, all suggesting that during that period of time, we had yet to truly optimize our antithrombosis regime, and that we were either under anticoagulating them or not adequately covering them during that period of time. And since over the last decade, we have made huge strides. And so the question is, well, how have we come to this point? And so here's just a few studies recently published, one by Dr. Rob Niebler, an intensivist who reviewed the PDMAX database. And this is international or North American registry primarily at this point of mechanical circulatory support outcomes in children supported on VADs. And he now reported that there were a 10% rate of cerebral vascular events in this population, and that the Berlin Heart stroke event rate had decreased down to 16.9% as compared to 29% in previous studies. Dr. Safar also demonstrated stroke reduced by 44% and pump exchanges reduced by 40%. And that this improvement in outcomes in terms of stroke and pump exchanges was not just realized in patients on Berlin Heart, but it was also realized in patients on intracorporeal devices such as the HVAD or the hardware device with only a 4% stroke reduction, or with only a 4% rate of stroke. So how did we get here? And I think over the last decade, we definitely have a wider armamentarium of better devices that are available for children. We have more experience, both failures and successes, and I think our failures have been the most useful in informing how we proceed. We have collaboration, and this has really truly moved the field faster forward than I think any of our other endeavors could have. And we're also looking at old agents, specifically direct thrombin inhibitors, and potentially using them in new ways. So briefly, I'm just going to talk about some of the better devices. And just as a very brief overview for those not familiar with all the different types of VADs out there, VAD standing for ventricular assist device, we categorize them based on the position of the pump in relation to the body. And so extracorporeal, or normally kind of referred to as ECMO, really refers to the pump kind of sitting adjacent on a table in proximity to the patient with cannula that are then directly inserted to the patient. And while many of us don't consider ECMO as a long-term support strategy, this support strategy can be considered durable or long-term if the cannula are tunneled in a fashion that the chest can be closed, the patient can be extubated and ambulated. And so, for example, this boy with Glenn Physiology was supported for over 6 months on an ECMO machine connected with Berlin heart cannulas. Paracorporeal devices is where the pump is in close proximity to the chest, as you see with this little girl sitting on her ICUS with a car seat, it's the pump. The pump is connected to the heart with these cannula, and ultimately with the Berlin cannula, you can connect it to a variety of other types of pumps in close proximity, such as Pediatric, Centromeg, Rotaflow. And now the newer generation of pumps include intracorporeal devices, such as the Heartware, which has now been removed in North America by the FDA, and so no longer will be available to children and adults alike, although children actually had very good outcomes on support as compared to adults. But now this will be replaced by the HeartMate 3, which is an intracorporeal continuous flow device. There are other investigational devices such as the Jarvik, and then percutaneous devices such as the Impella, which is placed in a hybrid fashion in either a cath lab or in the OR, where the pump is placed in a retrograde fashion through an artery into the ventricle and can be secured in a fashion such that it can be durable. And so when we look at all these devices, kind of the most important thing, at least that I think about, is not only where the pump is and how the patient will ambulate, but what is the hemocompatibility? And we know that all of these devices have varying hemocompatibility, with improved hemocompatibility with the newer generations that ultimately have less biomaterial interfacing with the endothelium and the blood. And so, you know, I think our field has really been focused on thrombosis, coagulation, and platelets, but there's so much more to device design in which we can actually have actionable targets to improve these outcomes. And I'd like to move on to experience because I think this is really what's fostered a lot of our improvements in the outcomes of these patients. And so when you look at just over the last 7 years, from 2013 in the PDMAX registry, which is this North American registry of durable mechanical circulatory support devices, you can see that there's been this tremendous rise in device utilization. And this really only captures, a fraction of the devices that are put in North America total. And so we know that this field is expanding exponentially. We also know that the outcomes of these patients are improving such that the percent survival of patients on these devices upwards of 1 year is 70%, which is in stark contrast to ECMO, where most patients, or more than half of patients, have died by 3 months of support. But one of the main issues remains with all types of devices is stroke. And as you can see here, this is a time to stroke where you have intracorporeal devices such as the HVAD represented in green, the Berlin Heart in blue, and other types of paracorporeal devices such as Rotaflow, Pediatric in red. And that these patients, that there's device-specific differences in risk of stroke, suggesting both a hemocompatibility related issue, but also a patient-specific issue, given the fact that intracorporeal devices are generally placed in older children as compared to paracorporeal devices that are placed in smaller children, where intracorporeal devices are too large for implantation. And so when we look at the current era of adverse events in VADs, we still know that the highest rate of AEs occur in the first 2 weeks, and that over 56% of children will experience some form of AE during their support time, with infection, bleeding, and cerebral vascular event being the most common. We know that the incidence of hemorrhagic stroke is actually quite low at only 3 to 6%, and it still is a predominance of ischemic stroke. And so based on the most recent PDMAX analysis, they suggested that more aggressive and effective anticoagulation is kind of the future of improving outcomes in this population. And I would argue that I don't think we need more aggressive anticoagulation, we need more effective anticoagulation. And that was actually one of the nituses or catalysts for creating action, which I'll speak about in just a moment. And this is where it goes to collaboration. And so what is action? Action originated from a common problem that a bunch of physicians, nurse practitioners, providers, patients, families were all enduring. And that was stroke in pediatric VAD. And over years of managing these patients, we felt that we were encountering the same problems. And so as a result, we all got together in a formal manner and we pooled our data and outcomes and we shared our experiences, and we did it in forums such as group emails and then in Zooms and in conferences, and becoming more and more of a formal organization, but with a common mission to improve critical outcomes for children and adults with congenital heart disease or with acquired heart disease by learning together and changing the field quickly. If this is a very complex diagram that just shows who action is, and the names isn't important other than to show that we really try to diffuse the power structure over a multitude of individuals, because we realize that any project, any advancement that gets done with help of so many other individuals, not just necessarily the lead PI or the most senior person. And so as a result, the structure of this organization includes a multitude of individuals and just continues to grow. One of the main projects that catalyzed action was the adoption of bivalirudin, and this started at just a few centers, Edmonton being one of them that started using bival for complex patients, and then our center utilizing it, and then sharing our experiences just through word of mouth, and then creating kind of a formalized protocol for adoption of this. And over a 2-year period, we were able to reduce strokes from 30 to 12%. And it wasn't just the adoption of a new agent, but rather it was the standardization of the way that we monitor and manage and communicate antithrombosis goals that I think has really changed the outcomes for these patients. And so lastly, I'll just finish with how we've been utilizing old agents in new ways. And I know that we're coming to the end of the session, so I'll try to speed through as much as possible. But when we look at anticoagulation options for children, and Dr. Chan's done a wonderful job reviewing them, we have, the top 3 that have really been the cornerstone of antithrombosis therapy: unfractionated heparin, low molecular weight heparin, and vitamin K antagonists. But we have other agents available to us that is expanding, and this includes direct thrombin inhibitors and the direct oral anticoagulant medications. As a non-hematologist, I always looked at heparin as a frenemy. And for those not familiar with this term, it's a person with whom one is friendly despite a fundamental dislike or rivalry. And particularly in the ICU, there is just an abundant use of heparin as though it's kind of water that's just dispersed within all of the IVs and central venous catheters, with this expectation that it just has magical properties. But I've tried to express to people that there are potentially harmful effects of heparin if we don't totally appreciate all of its interesting caveats. And so going along with heparin as a frenemy, I always would say that heparin was coasting on a reputation. It's a WHO named required medicine. It has a long history of use in adults and children, and so we've taken it as just a standard of care. But it can be unreliable. It's unfractionated, and this denotes the fact that it's not been fractionated, resulting in variable size of molecules. As such, each of these variable sizes have variable activity against thrombin and factor Xa, such that there can be great variability in effect between vials, because each vial only contains 1/3 of the 18 saccharide unit required to bind antithrombin for thrombin inhibition. It's also dependent on others to get the job done. It needs antithrombin to potentiate the inhibition of thrombin, and this can be a huge problem in children who have low antithrombin for physiological reasons of developmental hemostasis. It's unpredictable and clingy. It has nonlinear dose response, pharmacokinetics, and pharmacodynamics. It sticks to anything positively charged, so in a VAD world with a lot of plastic, this can be a problem. It also can cause unnecessary drama in an already stressful situation. So exposure can result in HIT, which we've seen in our cardiac population. It can also cause osteopenia. And especially in pediatric cardiology, you can't really avoid it. There's pervasive use in the hospital, and many people have a false sense of security when heparin is ordered, when in fact it could be doing nothing or worse, causing problems. And so I think after a lot of our experiences with heparin use in mechanical circulatory support, we did seek out other options and other alternative therapies. And that's where we looked to agents such as bivalirudin. And I think some of the things that attracted me to bivalirudin was that it appeared to be more reliable. And by reliable, I mean it was there when you needed and it was gone when you didn't. So it had a very fast onset and a short half-life. Now, while this agent doesn't have a reversal agent, its half-life in a patient with normal renal function is approximately 19 minutes. It's more predictable, and this is exceedingly important when you're dealing with high-stakes thrombosis management in mechanical circulatory support with linear dose response curves. And it's not dependent on others to get the job done, with no dependence on antithrombin and no other interactions with food or impacted by liver function specifically. However, there are downsides to bivalirudin, being that it does have proteolytic degradation, with about 20% of it being renally excreted, and as I said, no formal reversal agent. We've been monitoring it with a prothrombin or an APTT or dilute thrombin time, but beyond the time for this discussion, there have been challenges in identifying the ideal fashion in which we can monitor bivalirudin. But with the current data that we've acquired through ACTION, we have demonstrated that there is definitely a higher time in the therapeutic range when using bivalirudin or direct thrombin inhibitors as compared to unfractionated heparin. This is just a picture of the bivalirudin harmonization document that was created amongst many institutions within the ACTION network. It by no means is has not been validated in any randomized controlled trial, but is just a culmination of many centers who've pulled together their experiences and tried to create kind of a best practices for approaching the use of this agent. And then moving on to other agents, the concept of using DOACs for mechanical circulatory support is not necessarily new, and in many ways would seem like an ideal solution, given the fact that for patients who are supported on devices, they might need to take this agent for years. And so finding a stable, reliable agent that can be easily administered is ultimately the holy grail of what we're trying to achieve. There have been a multitude of case reports looking at different DOAC use, and ultimately agents such as dabigatran have failed when applied to mechanical circulatory support, but that we are hopeful that there can be potential application of select agents, specifically apixaban. And Francesco here reported the use of anticoagulation with apixaban in a patient with a left ventricular assist device as an alternative to warfarin. And since that time, there's been a multitude of other case reports and case series, most recently published abstract looking at the use of Eliquis for patients with intracorporeal VADs, namely the HeartMate 3. And ultimately demonstrating that the overall rate of stroke and bleeding events was comparable or lower compared to that of using warfarin. Here at Boston Children's Hospital, we have a lot of real-world experience using apixaban. As part of the saxophone trial, we were very engaged with recruiting patients with acquired or congenital heart disease for thromboprophylaxis with apixaban. And ultimately, COVID dramatically impacted how thrombosis management looked like in children. And so here in Boston, patients couldn't get to labs to monitor Lovenox levels or warfarin. We had a shortage of strips for Coumadin management, and so we took the leap of transitioning many of our patients to standard commercially available doses of apixaban. And so far, we've used apixaban in more than 260 patients less than 19 years of age for the treatment and prevention of thrombosis. We've used it across a multitude of different indications, including now the standard of care at our center for HeartMate 3, and in use in one patient on the Berlin heart. Out of this cohort, we had 20 patients who have had minor bleeding events, of which actually menstrual bleeding has been one of the main issues. 3 patients with clinically relevant non-major bleeding, also related to menstrual bleeding or nosebleeds, but no major bleeding events. And we've adopted this practice using level-based dosing because in-house we're able to achieve we are able to measure an apixaban dose, which is a chromogenic anti-10A level, which over time we've been able to correlate using kind of the rough guides that was used in the Aristotle trial. And so we hope to get this data out shortly so that we can kind of collaborate and work together with other centers to gain, as well as data through the saxophone trials and other ongoing trials, so we can put together both the real world data and formal study data. I always say that nothing ever goes away until it teaches us what we need to know. And I think stroke and thrombosis and hemocompatibility is still just a very emerging field when it relates to mechanical circulatory support. And so as just the last few slides, I think we need to look beyond therapeutic targets of anticoagulation and look to other agents. And really focus on platelets, hemolysis, inflammation, and immunology. And so looking just at hemolysis, I think hemolysis is one of the major causes of multi-organ failure on mechanical circulatory support and is generally underappreciated in this population because ultimately we have little to nothing to do about it. But it's been shown to be a significant prognosticator for mortality in mechanical circulatory support. We know that the effects of free hemoglobin are both slow and fast killers in causing a multitude of end organ dysfunction and disability, scavenging nitric oxide, causing vasomotor instability and vasoconstriction, and ultimately creates the appearance of multi-organ failure in spite of having adequate support on mechanical circulatory support. And so I think as a future direction, we need to focus our attention on mitigating hemolysis as well as having therapeutic targets for free hemoglobin. And inflammation is also becoming more appreciated as a potential antithrombosis strategy. And so there have been studies looking at the use of steroids for hyperfibrinogenemia. And this in many ways has become kind of a non-official standard of care of using steroids for early suppression post-cardiopulmonary bypass to reduce inflammation or just to manage hyperfibrinogenemia in patients on VADs. And so with that, I would like to say that we've made dramatic strides in improving outcomes for children supporting on VADs, namely in reducing bleeding and thrombosis, and that Dr. Patti Massicotte has ultimately become the fabric of the strides that have been made. There have been definitely changes in agents with increased use of bivalirudin, namely for paracorporeal devices. And I think there could potentially be a future role of DOACs for intracorporeal devices and potentially even paracorporeal devices. And we need to appreciate the impact of VADs on endothelium and examine targets beyond just thinning of blood. And so with that, I'd like to dedicate this to all of those who have trusted us with their lives and the loved ones in the pursuit of bettering the lives of others. And as Dr. Patti Massicotte would say, let everything happen to you. Beauty and terror, just keep going.
Thank you very much, Christina. And I really have to apologize that we were already running a bit late. So you had a difficult task to speak under some time pressure. Unfortunately, we're running too late now for any further questions, but you have covered the area very well, and this was a very interesting talk that was going far beyond anticoagulation only. So I would like to close this webinar now by thanking all the speakers and discussants. We have heard excellent presentations covering thrombosis and hemostasis from our basic understandings, basic research, pathophysiology, epidemiology, but also reaching towards treatment of complex situations such as stroke, as well as preventing stroke in ventricular-assisted devices. All these advances that we have heard about and that we have seen over the last 2 decades are founded on by Maureen Andrew's work and all her associates, and I think this was an excellent webinar to celebrate all these advances. I thank you very much, and I'd like to close this session. And bye-bye to everybody.